and today on behalf of Mero Eye team, I'll be hosting the current session. And I extend a very warm welcome to each one of you who have been connected with us to our iTalks webinar. Also, I would like to thank you all for taking the time out from your heavy schedule and marking our program with your glorious presence. Thank you for joining with us this evening. And also don't forget to subscribe our YouTube channel for being updated to our programs even in the upcoming days. For now, I would like to step forward to inaugurate today's session, and also I would like to notify you all that we will be having our discussion session at the end of the webinar. So if you get any queries in between the session, just drop them on our comment section. We will get back to you later on. Today, as a speaking delegate, we have Dr. Cathy Stern, all the way from USA, and she will be talking about why do I add vision therapy to my practice. Before she begins, I would like to give her a general introduction. Dr. Cathy is an OD, Fellow of College of Optometrists in Vision Development and the College of Syntonic Optometry, and also of the Neuro-Optometric Rehabilitation Association. She is a developmental or behavioral and neuro-optometrist with specialized training in learning-related vision problems, vision rehabilitation, computer vision syndrome, and sports vision strength training. I welcome you, Dr. Cathy, on behalf of Mero Eye Foundation and all our participants.
Thank you. Let me get my slides up here. Okay, so we want to talk about why you should add vision therapy to your practice. I can tell you that I started off in optometry with what might be called a general practice. I pretty much did a little bit of everything, but I added more vision therapy over time. And then after about 10 or 15 years of doing that, I decided that some of the other things were changing and maybe not as much fun to do for me. And so I decided that I would make my practice be all vision therapy and vision rehabilitation. And it has worked out very, very well. And I get to have much more of a relationship with patients, and I enjoy it a lot. And there are certainly other doctors around that I can refer to for things that I don't want to do very much. It's not, when I say vision therapy, it is a combination of what I'm going to talk about today, which is really how you can even make it a simple part of a general practice without even doing active vision therapy in your office. And also I do a certain amount of contact lens work also, because I've always done myopia control. And even in terms of prescribing, I like to be able to have patients have the kind of prescription that I would want and not just what they show refractively. So we'll talk about that. In fact, I've had patients have to move or move away, and they always say to me, do you know somebody who's going to do it the same way that you do it? So it's important to them. So I like to say that everything you know, you learned in optometry school. It's not something you don't know. It may be something you don't pay as much attention to on a daily basis, but I think you can find that you can add it into your general practice. It won't take much longer in terms of your initial exam, because I did it myself for many years. And it will then allow you to do more active vision therapy, or maybe you want to just give people things to do at home, but it will add an aspect to your practice that I think, one, brings you income, two, gets you known for doing something a little bit different, and I think it's fun and keeps me thinking and doing something interesting all the time. So what are some of the things that I want to try to do here today? I would like to have you learn some techniques, or at least talk about some techniques that don't take much time. I want you to appreciate that you can not only maximize the patient's success with vision therapy, but yours as well. We want patients to not only see well, but we want them to be able to learn faster and learn easier, and work faster and work easier. And you're going to see that some of these things you can start tomorrow. So how do you want to address patients' concerns? So there's a few things. One is when, especially a child, and I'm going to talk today mostly about children because I think we all see or will see a lot of school-age children. I do work with a lot of adults as well, but I think for starters, it's good to think about helping children because at least here, parents are sometimes more willing to do things for their children more than they're even willing to do for themselves. So the first is to always listen to a mother's concerns. And I'm not discounting fathers here. It's just that we do find that mothers are bringing their children more often, although we ask right on our history form that both parents come to the examination, and sometimes that happens, sometimes it doesn't. But basically, you'll find that sometimes parents will tell you they've been concerned about this for a while, and maybe their child has even had a vision exam or an eye exam somewhere else, and the other doctor didn't even address the concern, let alone do anything about it. And this is a quote actually here from a parent, and she said, "I know there are many children out there who have been misdiagnosed or labeled with learning disorders when what they really need is you." And what she was saying is that I am not suggesting in any way that what we do is going to eliminate a learning issue that a child might have, or even an adult may have. But sometimes what looks like a learning issue is a vision problem. And once the vision problem is addressed, they don't have what looks like a learning issue anymore. Years ago here, there was actually a group of psychologists, a very small group, and they used to do a very brief vision screening before they would do their neuropsychological testing with anyone, because they understood that if there were visual issues, at least the things they were screening for, that it would have an impact on the testing, and that the testing would not reflect just the learning issues or maybe the psychological issues that someone would have. We don't see that very often, but I thought that was great. So when does it really start that you're going to talk with someone about vision therapy, or even about how you can help them? I think it has to begin when they call your office, and whether you answer the phone or you have someone else who takes the calls, they have to be prepared to answer the questions that people may ask and to let them know what you do. So the first thing is, what do parents say when they call, or what do patients say when they call? So we have here school screenings. Usually it's just a chart on the wall that a child has to try to read. I think in some schools they may have a stereoscope with some cards, so they may be looking a little bit at their phoria or their stereo ability. So it's different in each place. But basically, sometimes the parent gets a letter that their child failed a school screening. And a lot of parents don't take children for an annual eye exam because if they think their child is seeing clearly, they don't think it's important. And we have a lot of pediatricians here who also test them on like a chart on the wall. And because they do that, many parents, when I say to them, "When was your child's last vision exam?" they will tell me it was in the pediatrician's office. They think it's an eye exam. They don't really understand all the aspects or all the parts of an exam, even if they themselves see an eye doctor. And sometimes they just call and they say, "I just want to make an appointment for my child." And then it's our responsibility to say, "Well, is your child struggling in school, or is there something in particular that had you giving us a call because I don't find very often that someone says, oh, I just thought we should start having them have an annual eye exam. It's not like the dentist, where, you know, we have a lot of commercials here on television that say you should see your dentist twice a year. And parents know from a young age to bring their children to the dentist, but we don't really have anything like that suggesting that it's important for them to bring their children for an eye exam. And then I think it's important for you or your office to let parents know that you have, for example, special training in examining children, or that you can help vision problems that may be affecting their learning. Or if they've had an accident or an injury, that these are things that you do. I think now that there's more awareness of concussion and more awareness of, or starting to be more awareness of, myopia control, that maybe parents will even let us know that that's something they're interested in, and they'll call us. I had a phone call the other day, and my office person is actually working from home, and she let me know that a pediatrician from probably a 6-hour drive away, I don't know where she got my name, called because she wanted to know if we do vision therapy online, because I was surprised because not very many pediatricians are that knowledgeable or supportive of vision therapy. But I don't know if a parent asked her, and I don't know how she found me. Maybe someone knew me, or maybe they had moved there from here, but she was looking for someone who could provide it online because the family could not go into an office right now, or in many cases, a lot of offices are still closed. So I thought that was very interesting. You know, you start to get known for this after a while. So here's a big thing. If you don't ask the questions, you won't know what's going on. So what's some simple things that you could be asking on your history form? The first thing we ask is, who should we thank for referring you to our office? And the reason we ask that is we want to acknowledge that person afterward, but also if it's another doctor, we want to certainly thank them. If it's another optometrist, I want to make sure they have either some of my business cards, or they have some brochures or pamphlets that we hand out in their offices so they can give it to patients. I want to make sure they have a form that just says, you know, what do you think is going on for this child? And it might have a few check boxes. One might say convergence insufficiency, or an accommodative issue, or just a learning issue. And then we made it so they can give us the patient's phone number even on that form. They can fax it over to our office or email it to our office. And we can call that patient and discuss things with them, because these doctors and you as doctors are busy, and that should be our responsibility. But if they're okay with that and the patient is okay with that, we try to have a form that they can fax over to us. You know, you could ask, can you describe any difficulties your son or daughter is having? That's kind of vague, but it's a starting point.
Please.
And then you can get more specific, depending on what they say as to why they called. You know, is your child at the level, should say you're, not you, is your child at the level you expect them to be? That's a nice way of saying things. You don't want to say, is your child behind? You know, are they failing in school? You know, sometimes you might have someone who's an average student, but the parent thinks they're smarter than that. I know every parent thinks their child is a genius, but aside from that, you know, it might be that when they just talk with the child, it's clear that they have a lot of knowledge, and yet maybe they're not doing well when they have to read a lot of text, or maybe they're not doing well when they have to take a test. And so the question becomes, are they doing as well as you think they can be doing? Are you comfortable with their performance? And let them know. Parents really need to be reassured. So you want to let them know based on the information you've given me, you've called the right place. What we do, and other offices as well, is we have a little form that we keep near the phone. And when someone calls, we get their name, we get their child's name, their age, the grade that they are in, and we ask them some questions and we make a few notes as they talk to us. And then on it, we have a place where we can add, obviously, their address or today their email, their cell phone. And then we either make an appointment, and then we have checkoffs for things like, did we send the history form? Did we send them other information? If they're not ready to make an appointment, we say, well, would it be okay if we just sent you some information about what we do and about how optometry can be helpful? And then we have a checkoff for that. You know, we sent a brochure, or we emailed a little booklet we have, or we, gave them some websites they could check out, so that we have a way of following up. Now, I don't know if you typically have some type of insurance there. We have here what we call health insurance. Many people have it, not everyone. I like to call it disease care insurance. If you are ill or if you have a disease, it will generally cover the visit. If you are having a basic eye exam, a very basic eye exam, we do have a lot of insurances now that will cover that every year or 2 years. But often the full type of evaluation that we will ultimately do for vision therapy is not covered. And so if they're coming in initially, we might say, yes, it'll cover this evaluation, so that we can have the opportunity to do even a few tests with them. And then after we do those tests, we can talk about doing more. And at that point, we'll let them know that they will have to pay for that on their own. But the one thing we try to stress is not to allow a third party, not to allow insurance or someone else who's trying to control the system, prevent them or their child from receiving the care they need. And that we're always going to make our recommendations based on what's going to help them, whether it's in school or at work or in sports, whatever it is. We do keep a lot of brochures in the area where patients sit when they first come in, and it has literature, for example, from the optometric extension program here. We have a brochure we made about our practice. We have some little cards that are just single cards. They look like the front of a brochure, but they're on a little bit heavier paper. And we have on that different topics. So we have one about reading and learning. We have one about sports. We have one about special needs children, with just a few highlights of the things they might be noticing, the kinds of things that we could offer to help them. And it's really kind of fun. One day, a mom and a daughter came in, and the daughter picked up the one about sports, and she took a pencil out and she was checking off some things. And the mother took one out about learning, and she was checking off some things. And when they came into the exam room, I said, you know what, I can keep you both happy, because the daughter cared more about sports. What child doesn't? And the mother was very concerned about school. And yet it's the same visual skills you bring to all those tasks. The other is, we tell everyone when we send a follow-up email, or when they make the appointment, we now send our history form out via email. But we also send on the same email a small booklet about vision therapy. And we, of course, have our website on it. But in any case, if they're not making an appointment, and if for some reason there's not going to be a follow-up email, we always suggest that they look not only at our website, but we may suggest other websites that are appropriate. Here, that might be COVD, the College of Optometrists in Vision Development, or the Optometric Extension Program, the OEP. But it's going to be somewhere where they can get more information. And we do keep a list of websites. We have them both on paper and already in a set email, so we can send that out. We do try to send a little bit about me when we first send them information. And we do have this booklet that we used to actually give out, the physical booklet, but now because a lot of it's done electronically, we scanned it in, and it has information about all the different aspects of vision therapy. And in each section, it has a little checklist. And we do find some parents print it out and they actually come in with it and they've already checked off things. So I know they're very serious about it when they come in and they've done that. How do you introduce yourself? Well, on our emails and in anything that goes out from here, we have my name, my credentials. We say behavioral, developmental, and neurooptometry. Some people might even say pediatric optometry because patients hear all these different names and they don't realize it's kind of the same thing. And then we have a tagline here we use, which is see better, learn faster, work smarter, play to win. So we're talking about helping people with things like myopia control. We're helping with visual skills for learning, visual skills for your occupation, and sports. And then on it, we also have our address and our phone and our email. Okay, can people still hear me okay? And what we also did is, and I can show it after, I can put my slides down and just show you some things, but we created a kind of a little postcard that looks like a very large business card, but it has my information like this at the top. And then the middle is empty. And anytime we write a note for a patient or we want to recommend something, we write it down on one of these cards so they have our information right there while they're making a call. It might even be when we want to refer them because they have a retinal issue or a corneal issue. We want them to have our name in front of them as much as possible and what we do. So what are some other things? Well, if you want to get known, I know here, especially some of our small community newspapers are looking for information and articles. So maybe once a month or once every few months, you could send them articles that are appropriate for that point in time. Maybe you want to say children should get their eyes examined before they go back to school. Maybe you want to talk about eye or vision problems and attention deficit disorder. Maybe you just want to have one that says 20/20 is not enough or 6/6 is not enough. Maybe you want to talk about myopia control. We used to send something out at certain holiday times here because children would, for example, in the summertime, they might be using fireworks, and we put something out about eye safety. So you can use things that other people have written. Just a week or so ago, in a very large newspaper here that's all over the country, there was a big article about myopia control. So you can capitalize on that, or you can write things yourself, whatever's appropriate to where you live and work. All right, how do you want to minimize testing? No one wants to do too much testing. The patient doesn't want to be over-tested, and you want to make a quick decision about their need for maybe more testing or more care based on only adding or the need to add a few tests because you're already busy and can only spend so much time with a patient. And you want to get them interested, at least at that initial exam, even if you're going to bring them back for more testing. And how do you do that? Well, one, you need to maybe, even when you send the history form, to use some kind of predictive questionnaire. What does that mean? Some of you may be familiar with the COVD questionnaire that's used. There's one for convergence insufficiency that has, I think, 15 or 16 questions. There's a longer one with 30. And what they do is they rate each of the symptoms on a scale of 0 to 4. Is it something they never experience? Is it something they always experience? And when you add up the points, for example, on the COVD questionnaire, they say if you have 20 to 24 points, maybe you have a vision issue, but you certainly should come in for an evaluation. And if you have more than 25 points, it's pretty predictive that there's going to be something in the visual system that's not the way it should be. And so what are we looking for? What are the kinds of things we want to ask? What are some of the things patients may mention? So one, we talked about if they do any kind of screening at school or in a pediatrician's office, a child may not pass. Does a child say their vision is worse at the end of the day? Now remember, especially with children and younger children, the way they see is the only way they may have seen. So I've had children here where they see double, and a parent wants to like crawl under the chair because they feel terrible that they didn't know their child had double vision. And as kind of a joke, kind of in a light sense, I say to them, last time I checked the parent handbook, I don't think there was a page that said you should ask your child if they're seeing double. Now, obviously, there's no such thing as a parent handbook. That's kind of the joke, that there's no rules about how to raise your child. But I want them to appreciate that their child isn't going to mention it if that's the way they've always seen. And there's no way they would ever think to ask that because it's not something they can see. If your child is dragging their leg or they're, holding their hand like it hurts, you can easily say, did you trip? Did you fall? Did something happen? But whatever's going on in that visual system, it's invisible. Maybe an occupational therapist in a school noticed that a child had difficulty with handwriting, or maybe they did some testing with them, and at least here, some of them will notice that some of the things they find may have a visual component to them, and they may recommend that they have an eye exam. If they go for just any exam, it's likely they're going to be told they have very good eyesight and healthy eyes. And in some cases, parents will be happy. In some cases, they're not so happy because they went to have this exam and they took time off to do it and nothing is wrong. But for the most part, I think they'll feel good if nothing is found and yet their child is still struggling. Sometimes, not often here, but sometimes the school will suggest that a parent get an eye exam because of what they notice in the classroom. Here, the problem is that if the school mentions it, often parents think then that the school should pay for the examination. So very often the schools and people working in the schools are told not to mention it because the schools really don't have much of a budget to be able to pay for that. And it may happen because a child skips or repeats lines when reading. I think that's probably the number one thing that we hear when families call or come in. Now, here's another one. There's a young boy named Jake, and we will get back to Jake as I go along, but he was complaining of being dizzy or being nauseous when he was doing a lot of near work, and I'll show him in a little bit. So remember, everything you learned in optometry school. So what are tests that you can do that are simple, that are quick, and that will demonstrate to a parent what's going on? So when someone is reading a chart, either at the distance or at near, you want to listen to the quality of how they're reading it. Even a parent can notice if they're struggling to read it. When you do a cover test, are you able to show the parent how the eyes jump a little bit and that that's not the usual way that it should be? Because if someone is struggling with binocularity and they don't have a constant strabismus, they're often going to be more symptomatic. In other words, they're going to tell you that words jump on the page or move on the page, or they lose their place, or they get very tired when they're doing near work, because they're constantly in this fight for the eyes to stay together. Once someone has strabismus, it may look worse. Certainly parents will notice if an eye is turning most of the time, but in terms of things like reading, it's much less interfering, because while we know it's active suppression and it's not quite the same as it would be if they could have binocular vision, they often tend to have less issues with some of the things that are mentioned by those who have less stable binocularity. If you're going to do a near point of convergence, which I urge you to do, there are a couple of ways we do it to show parents, and also to make it easy for children. So when I'm done, I can show you. I have a little finger puppet, and he has two pretty prominent eyes. And so I don't have to know whether a child understands the concept of double vision. What I do is I hold the puppet up and I say, how many eyes are looking at you? And even a 3-year-old can tell me there are 2 eyes looking at them. And then I cover one eye with a finger, my finger, and I say, how many eyes are looking at you now? And they say 1. And I say, that's great. I'm going to move this puppet a little bit. And if at any time he gets his 2 eyes back, I want you to tell me that. And there isn't a child in the world who then doesn't usually pay attention to it better, because now I've asked them to do a job. And as soon as they notice that he has 2 eyes, they tell you. I also can use a red lens test. If I see that the near point of convergence is somewhat fragile, I may quickly pick up a red lens, put it over one eye, and repeat the test with a pen light to see if it's even more receded or less stable. The other is, if you're going to do near point of convergence, they say it's best to do it 3 times, because I've had more than one patient where you do it once and it looks pretty good, and then you do it a second and a third time, and each time it becomes more receded and more receded because they are so unstable. What else? Color vision is important, not because a parent is always going to notice the child doing it well or not, but because, especially in schools and now on the computer, a lot of things are coded by color. And so there are even some websites where you can demonstrate to someone what it's like when someone has a color vision deficiency. And there are some websites or apps that can be added in to try to enhance the experience for someone who cannot see or use the material as well, because they're not seeing the differences in the colors. I even notice that sometimes it's hard to see some of the differences, maybe even on a graph or a drawing, because some people tend to use colors that are fairly close to each other, and depending on the screen, they may not look as distinct as you would expect them to. So you need to watch that when you're using color just generally. And then what happens when you do stereo testing? I like to show them the stereo fly, and I don't want a child to feel badly that they can't do it. So what I say to them is, sometimes the fly looks like he's flying up at us, and sometimes he looks like he's sleeping. Is he sleeping right now, or is he flying up at us? And I ask them then to reach out where the wings seem like they are, because they're being able to localize that not only tells me they really did see it, but it's another indication of how well they appreciate where things are spatially. And there are some RANDOT and other stereo tests now that can be done even without having to put eyeglasses on a child if they're reluctant to do that. The other thing I use a lot is what I call a near to far focus change. I hand the patient a card with some relatively small but readable reading material. Not the smallest you might test them with, maybe a couple of sizes larger than that, like they would generally have in a textbook or a magazine. And I asked them to hold it where they normally read. And then I put up on my chart across the room letters that are maybe 2030, 2025, meaning here, not quite 6'6", just a little bit bigger than that. And I asked them as quickly as they are able to look back and forth between the print without reading it. So you're going to look down, and as soon as it looks clear, you're going to look up. And as soon as whatever's across the room is clear enough to see, you're going to look down. And I'm usually standing to the side of them, so I can see their eyes going up and down, and I can see how quickly they do it. And I ask them to tell me if, as they do it, either the distance or the near gets blurry and doesn't get clear, or feels like it's getting harder or taking longer to get clear. I can usually see some of that because I'm noticing their eyes slowing down, but I like them to try to notice and tell me as well. And that is such an easy thing to do. You could do that in a classroom. You could do that anywhere. And I can't tell you how many patients, young and older, who do that, who are not presbyopic, who do that and really notice the difference. And not only that, if I determine they need, let's say, a low plus lens for near, if I put that lens on and put it so they can look through it just at near and not at distance, and have them repeat the test, you can see them going faster. They will tell you it's not getting blurry anymore. They will tell you they notice it's faster and easier, and they're thrilled. And it doesn't take more than something written at close. It could be a page out of a book. It can be a magazine. It could be a newspaper. And then having them look up far. Probably today with some people, what I would do is have them put up a website with some, I'd pick a website that had smaller print, and I'd have them just put that website up on their phone and have them do it. So this is one test of pursuits and saccades. I think besides an NPC, it doesn't take long to do pursuits and saccades. This is called the Ensuko oculomotor test. I don't know what is most familiar to you there. I use the developmental eye movement test a lot, but this one is one where you just hold up two objects. They generally suggest what are called wolf wands, which are just a stick with a ball on the end that is kind of shiny, so you can see yourself in it a little bit, or at least it attracts your attention. And you're just holding, either having them look at that one shiny ball and moving it in different positions of gaze for pursuits, or for saccades, you're holding one ball, and I have a gold one and a silver one. And so I hold them each off to the side a little bit and have them look back and forth as quickly as they can. And what are you looking for? Well, can they go back and forth 4 times? That would be a score of 4, which is good. You score it from 1 to 4. If they are accurate. So do I notice that they overshoot and come back, or they undershoot a little bit? For example, if that was noted 1 or more times, that would only be a score of 2. If they have any head or body movement. So if they have a little bit of movement of their head or their body, that might be a 2. If they're totally following with their head, that's going to be a 1. And the reason I say boys here is because the score can be slightly different for boys versus girls, especially at around the age of 5 or 6. And after that, it's pretty much the same. But girls tend to reach some of those abilities of being able to follow without the head movement a little bit sooner than boys. So if I do see someone, maybe boy or girl, who's 5 or 5.5, and even though I think at age 5 they should have that skill, if there are no other concerns and they're doing pretty well with everything on a daily basis, I would probably have them come back in 3 to 6 months so that I could follow up with that. Because if that skill doesn't get stronger and now the workload increases, they're going to have difficulty. So again, how long does it take to do these tests? I know we're busy, but you want to leave the patient with something that is meaningful. So if you do a cover test, if you do a near point of convergence, if you do some quick oculomotor pursuit and saccadic screening, and you do something for accommodation, like having them look back and forth, these things take less than 5 minutes. And I can tell you, I can probably do them in about 3 or 2 sometimes, depending how quickly the patient understands it. What's interesting to me is when I start my exam, I take a patient's acuity, I do a cover test, I do an NPC, then I do oculomotor, and then I may do accommodation right then, or I may do that a little bit later in the exam. But just doing those few things at the beginning, which take just a minute or 2, I can't tell you how many patients have said, or parents have said, wow, you do so many more tests than the last doctor we saw. And I'm like 3 minutes into a 30-minute exam. If you have a few more minutes and you want to do a little bit more because the person or the parent has concerns, you could use some kind of near muscle balance card. It's usually something with a pen light and a Maddox rod, so you can actually measure aphoria. What's interesting about that is if you do that, and while they're doing that test, or even the next test, the Worth 4-dot flashlight test, what will happen sometimes is you're standing still and they're telling you it's moving. Or you're doing the Worth 4-dot and they go, oh, there are 2 dots. Oh, there are 3 dots. Oh, there are 5 dots. Oh, there are 4 dots. And the parent is like looking at me like, what is going on? Because they notice I'm not moving. I'm not doing anything except standing there with my flashlight. And so it makes it very easy to talk with a parent about the fact that there's something going on here that isn't okay because they saw it. I'll often take out a Broch string and just ask someone to tell me when they look at a bead at near, what do they notice? And then I may take it across the room and ask them to do it at 3 meters. And when I do that, again, if they're not giving you the kind of response you'd expect, or it varies while they're looking at it, then a parent already knows that's probably not okay. The other thing we like to use here, which is a little harder for the parent to see and understand, but we have a Keystone telebinocular, which is just a stereoscope. And in the stereoscope, there are cards for acuity, but there are also cards that have on them essentially a measure of aphoria, a measure of fusion, a measure of first-degree stereo, so that we can do a number of tests very quickly. I also like it because when you're showing children often some kind of booklet, they know there's supposed to be something there they should see, and so sometimes they guess a little bit more. In the telebinocular, they really like it, and there's always an answer. If they're not fusing, they'll tell you there are 4 dots in the picture. If they're fusing, there will be 3 dots, but they don't know that. They don't know that 4 dots is not a good answer. Or they'll tell you that they're moving, and they don't know that that's not an okay answer. So I like it. And I know that kids really like looking in it because I have it on a small desk here in my examination room. And if they come back a second time, the first thing they do before they sit in the chair is they walk over and they put their head into the stereoscope because they want to do it again. So also, if vision therapy is not something that you want to do in terms of active in-office vision therapy, you can co-manage with other doctors who do it. You know, I know here very often optometrists are more quick to refer to ophthalmology or other medical specialties than they are to refer to another optometrist. There are things I don't do in my practice. I decided when scleral contact lenses came along that I wasn't going to do a lot of them, and so I don't do them. So if I see a patient with keratoconus, if I see a patient with particularly dry eyes, I refer them to a colleague for an assessment of whether a scleral lens or a specialized contact lens might be appropriate for them. Even if they have eye disease, I don't always send them directly to a retinal specialist or a corneal specialist. I have colleagues who are really good with eye disease, way better than I am, because I work with a lot of children, and so I don't see as much eye disease as they do. So if I have any question, I send them to a colleague first if I can. If I think they need treatment that it's unlikely that colleague will be able to do or that we're not licensed to do, then I will send them directly to ophthalmology, or even another specialty. I mean, if their blood pressure is high, or I see, a small hemorrhage in the retina, obviously I have to send them back to a general practitioner, or I may wonder if a medication they're on is a problem and send them back to the doctor that referred that put them on that medication. So I think we have to use everyone, but I think that at least here, a lot of doctors seem discouraged by general optometry, in part because over the last maybe 10 or 20 years, we have more limits on how we can get paid for a lot of this. And so while our costs have gone up, some of the reimbursements we get for these things have not really gone up that much. And so I want to say to them, instead of complaining, and believe me, we're not the only ones. I sat at a table one day with a group of dentists because we were trying to have a meeting between optometry and dentistry. And we were supposed to come up with some ideas for things. And the dentists at the table were all complaining about dental insurance and what it doesn't pay. And finally, I said, we could sit here all day and complain, but if we want to keep our practices going, what are things we could do to help each other? Maybe the dentist, because parents do take their children to a dentist, should say, when was the last time you had a vision exam? Maybe we should be asking in our offices, has your child been to the dentist this year? It would go a long way toward helping both of us. And we have no, what they call skin in the game, meaning if I refer to a dentist, there's nothing about that they're going to say, oh, she just did that because, she can make more money when I need eyeglasses or whatever. It's not going to be that, because they don't do what you do and you don't do what they do. That's what you want. And you really do want to think about your colleagues. I'm trying to show you things you can do in your general exam. When I didn't do vision therapy as much as I do now, when I actually first got out of school, I was working for some other doctors. There was no vision therapy in the office, but I can tell you that I did a lot with prescribing lenses, near point lenses and specialized prescriptions, and looking to do anything to slow down their myopia. And I did a lot of that without doing any active vision therapy. And not only were the patients happy, but the doctors were happy, because most of them also dispensed eyeglasses, and it meant they were selling more eyeglasses. And again, I don't have a problem with that as long as it was what I call a win-win. That means that we want to know that it's the right thing for the patient. I'm not going to suggest to them they get things they don't need. But if it's the right thing for the patient and I can make an income at the same time, everybody makes out. It's not a bad thing. So how do you integrate the history, the symptoms, the evaluation? Let me show you. So what are you going to look at? Well, what if they failed a school screening? What if they also say they see worse at the end of the day? Maybe they have poor acuity. Maybe they just have a receded near point of convergence, and by the end of the day, they're having some myopia that will go away by the next morning. What if an occupational therapist suggested an exam because of poor handwriting? Well, maybe you find they have a high exophoria or esophoria, or maybe they have a strabismus, especially an intermittent strabismus. What if the school system suggests an eye exam because the child is skipping lines while reading, or they're having trouble copying from a chalkboard or a whiteboard or whatever they're using these days? Maybe you now find they have poor oculomotor skill, poor accommodative facility. These are all these things that you can test for in just a few minutes. What if they're just coming in for an annual eye exam, but you've asked them to fill out one of these predictive questionnaires, and now they have a lot of points? Well, there are many different things that you may find, but by having questions on your history form, by doing these predictive questionnaires, I think a couple of things happen. One, patients are going to get more of what they need. Two, it sets you apart as someone who understands these things, cares about these things, and can help someone with these things. Three, it educates the family, because when they read, does my child have trouble with reading comprehension? They may stop and say, does that have something to do with vision? I've had adults say to me, at the end of an exam, if I see some tests that are a little bit low, like their Vergence testing at near, I might say, do you have difficulty with your reading speed or your reading comprehension? And they'll say, yes, but what does that have to do with my eyes? And what they mean is, what does that have to do with my eyesight? My eyesight is fine. And I then have to educate them. But you want to educate all along the way. Just the fact that you're asking these questions lets parents know that you're concerned and that what you do is likely different from a basic eye exam, or certainly the kind of screening they do at school or in a pediatrician's office. Let them know that you can help. Educate them, even if they're not ready for what you're recommending. Make sure they leave the office with a booklet. Make sure you maybe follow up with an email with some information. Try to see if you can have them go out and look at certain websites. Sometimes now, because they come in with a smartphone, I'll have them bookmark the couple of websites I want them to look at right while they're in the office. So I'm pretty sure they're going to go back to them. And what are the treatment recommendations? Well, you don't want to overwhelm them at first, and you may not need to. I have many, many patients that I prescribe lenses, and then I have them come back in 2 months. And sometimes that's work for a while and then may not work quite as well. If that's true, there's more that we can do. But I always tell them I don't recommend step 3 until I've tried step 1. And I think they appreciate that. So let's get to Jake. You want to start having success before they even come in. So you've given them this predictive questionnaire, and a lot of the symptoms that Jake is having and that he's told his mom about are on this questionnaire. So already the mother has confidence in you because she saw that the things he was describing are things you were asking about, and you've never met Jake. So you essentially recognized there may be a problem even before you saw him. And it's then more likely the family's going to follow your recommendations if they can. So here's Jake. He's 9 years old. He's in the 3rd grade. He says that he gets dizzy after he reads for 30 minutes. He's 20/20 or 6/6 at distance and at near. His cover test and his near point of convergence are normal. The Keystone Skills profile that we do, everything is normal. You do oculomotor testing. He can inhibit head movement, but he does use some motor support. So what does that mean? That means when I went to do pursuits, he started to move his head to follow. But when I asked him, could he now follow it without moving his head? I never tell them that it's wrong. I say, that was great. Did you notice that you were following it with your eyes and by moving your head? And the vast majority of children will say yes. And I go, now I'd like you to try doing it without moving your head. And it's very cute. Some of the children take their hands and put it on each side of their face to try to hold their face still. You can see some of them working really hard, tensing all their muscles, trying not to move their heads. But in this case, they were moving their head, but when I asked them not to, they could do that. The other thing you will see in a percentage of children is you need to watch their mouth, and even if you can get a sense of the tongue inside the mouth, because they will move their mouth side to side and even in almost a little circle as they're following rather than moving their head. But again, they're using motor support. So when I do a subjective refraction, he's plus 50 in one eye, he's plano in the other eye. But when I look at near, he's 4 of ESO. Well, he should be ortho or even low exo, probably 4 to 6 exo. When I do plus and minus to blur, he does pretty well on the +2, but he only gets to -1. That's not okay. I do his accommodative ability, and it's 4.5, when in a young child, it should be 10. And when I look at convergence, the break point of 16 is a little low, not terrible, but his recovery of 4 is not very good. But on divergence, he does pretty well. And when I do what we call a fused cross cylinder, we use cross cylinders in front of a chart that has vertical and horizontal lines crisscrossing each other. And we ask them as we go from plus to plano, low plus to plano, which lines look subjectively to them blacker or darker. And what you'll find is that often before you get to plano, that there's a place where they are balanced, where they look even, or maybe it switches from the vertical being darker to the horizontal being darker. That tells you plus acceptance for near. So now you see a little difference between his eyes. So something's going on there. When I look at that plano with the plus 50, I go, that's like having a little bit of myopia in that eye. He's ESO at near. That's not okay. His NRA, PRA is not balanced. His accommodative amplitude is low, and his recovery on convergence is low. And he's showing me that maybe plus 75 at near could be useful. Now, if another way to look at that is, if you look at the fused cross cylinder and you see what it is, then when you look at the NRA, PRA, if you balance that, so for example, if I take the 2 and the 1 and I add it together, I get 3. Half of that is 150. So to make it balanced, that 1 should really come up by a half. So what it tells me is that, that they could use at least a plus 50. And I know that might have been a little confusing, but it's just another way to kind of look at the two tests. And I had him do that distance to near focus change that we talked about, just with some print. And the near got blurry. And when I redid it with plus 75, and in this case, I added 2 prism diopters, bases down in each eye, because I find that's quite helpful in kind of opening up the visual field, especially in a child who's ESO. He could go back and forth, no problem. So I prescribed for him that plano with 2 bases down each eye and a plus 75 add for near. If a child doesn't want to use a bifocal, or today, because a lot of them are on screens and they won't always be looking through the bifocal like they should, I generally now tend to recommend a little bit more, maybe a single vision lens, but in a frame that is not too deep from top to bottom and has a fairly straight top on it, so that they can just push it down their nose just a little bit and use it like a bifocal, with nothing when they look up and the plus for near as they look down, and they can push it up their nose when they're doing all near work, like when they're on their screen. And now he's 10, now he's in the 4th grade, comes back, he's 6 of exoit near. That fused cross cylinder is +1, so it's he's still showing wanting that near, and his NRA, PRA is still not great. So what are we going to do next? Well, we might give him some accommodative work to do at home if I don't put him in a full office program. But the thing is, you can easily give them an RX for near or a bifocal or a multifocal or whatever you're comfortable doing these days. If they're developing myopia, you can look at lenses which have shown some promise, but not a lot in terms of myopia control. But if you do contact lenses, I don't know if you have the new MySight lens there. You probably have things there before we get them here. But there are a lot of new eyeglass lenses and contact lenses coming out for myopia control. Call a colleague for a second opinion. Believe me, I called anyone I knew years ago when I got stuck, and I still call colleagues when I get stuck. Okay, I still have days that I wake up and I feel brain dead, and sometimes it's just talking through it with a colleague. They don't even have to answer what I'm calling about. As soon as I've talked it out with them, I go, oh, never mind. I know now what I need to do. And I have colleagues who I think know way more than I do, and they call me sometimes too. We just need that sometimes to be able to kind of bounce it off someone. And then once you prescribe something, make sure they come back for progress testing, and also ask them to call you if symptoms return. So if they're feeling better, but it's not 2 months, it's a month, and a lot of it is coming back, maybe, it's around exam time in school or something, then you want to see them sooner, because maybe you will need to do more active vision therapy or refer them for that. And so basically involve the patient. Kids want to know, why am I going to vision therapy? Well, remember, you told me you wanted to be able to jump rope in gym class, that they were doing that and you couldn't do that very well. Maybe you told me you wanted to read easier when you're forced to get up in front of the class and read. Or, gee, you know what? You told me at the beginning, because I have every child before they start vision therapy fill out a form of what they want. If it's not active vision therapy and I'm giving them lenses, I still write down everything the child says. I always talk to the child. It's usually before I talk to the parent, because they're the most important person in the room at that moment. And if they say to me, well, I'd like to get my homework done faster, or, I'd like to not lose my place when I read, I write that down because I want to ask them about that the next time, because the family maybe didn't know it was a concern until they came in. I often will repeat the predictive questionnaire, and I can show them that, they had 30 points and now they only have 15 points. And I always recommend that they spend more time outdoors, not just because of myopia control, because that's what kids should do. And try to have parents limit television and video game time, and especially now where children are doing so much learning online. I took a class the other day myself, and I was really paying attention, and except for a very short lunch break, it was all day, and my eyes were exhausted at the end of the day. Now I realize I'm not young, and so that's part of it, but I know that kids are telling us their eyes are tired doing this stuff. It's not easy. And always give them some literature, have something. It's either your own handout or you can use pamphlets and brochures from other organizations. Refer them to websites. Today, websites are the big thing. When they were newer, maybe not so much, but there isn't a parent in the world who, the minute someone says to them, maybe you want to think about taking them to someone who tests differently or someone who does vision therapy, that they aren't already on the web looking all this up. And let them know that there is help. This is not something generally that they or their child have to live with. And it will help you. It's much more fun to do this work. I get to know the patients better. My schedule's more manageable. I don't need to see, 4 or 6 patients an hour. I see 1. And in our office, we put out a book that has success stories that families have written. And sometimes we send some of those out to a new patient. We'll try to find one that sounds like it's a similar age of a child and a similar condition or struggle they're having, and let them know that this is what happened after vision therapy. And then the big thing, not only can we help each other, which we should be doing, then we can help our patients to be successful. And that is all I have there. And I'm going to stop the share so you can see me, so I can just show you, like, here's my little finger puppet. And he's lost one arm over the years. The kids like to take the arms and pull them off. But I like his eyes because if you can see from the side, they kind of pop out. They're not flat like a lot of them. And I literally hold it up. They see two eyes. Now they see one eye. Tell me when he's got two eyes again as I bring it toward them. It makes it easy. I don't have to know if they understand double vision. Sometimes I will let them pick a picture. I have a little stick with some pictures and I let them pick. And when they pick the picture, I say, okay, you might notice two of these. I want you to tell me if you ever notice two of them. And again, I bring it toward them and back. But they're more engaged when they have a part in it. And when I have them look back and forth, I have a card with reading material. I may pick, this is the smallest. I don't pick that. I pick something more like what would be in a book. They hold it and I have them look down and then look up across the room and back down and up. And I say, I don't want you reading it. I just want you to tell me as soon as it's clear, then I want you to look up. As soon as it's clear, I want you to look down. And then just tell me if anything feels like it's not clearing up or getting harder to make clear. Simple, easy, takes a few seconds, is really demonstrating to the patient that I understand what's going on, demonstrates the problem to them, and is very easy for a parent who's sitting in the room. And I do have parents generally sit in the room unless the child like can't pay attention and just wants to pay attention to the parent. Usually what I do is if the parent has to go out, I'll stop the exam in the middle. I let them go out. I say, go get a hug, and they get a hug from their parent and then they come back in. But this is something that I did in my general practice without a lot of active vision therapy for many years before I went to do all vision therapy. If we all did this, we'd be busier, we'd have more income, and many, many more people would be helped. So I'm going to look in the chat right now. I'm going to pop the chat up and see what the questions are. And so far, I don't see any questions. I see some thank yous, and thank you all very much. I know it's a little bit late there. Yeah, someone have a question?
Yes, ma'am. This is Ajit again. I have two questions to ask.
Okay.
This is first question. How do you think that this monocular accommodative facility and binocular accommodative facilities should be in this battery of tests? Because it gives MAF gives the accommodation and BAP gives both accommodative and convergence data. So if we can do that, it will save time. What do you think?
Well, I have a whole battery that I do when I bring them back for a full vision therapy evaluation. And I do monocular and binocular accommodative rock with a ±2 at that time. In my initial exam, I feel like I get enough information from looking at their accommodative amplitude and from my fused cross cylinder and even my NRA, PRA. And more importantly, I want to know how it is in real life for them, not just on a test. So giving them a card and having them look back and forth tells me what it's like for them more in the real world. And so I save that for my battery. But if that's something you like to do and it gives you a lot of information, which it does, and you think you can, I mean, it's very quick. So if you want to do that initially, that's fine. I know that in some cases, a number of these tests I do in my phoropter, which you can kind of see behind my head here. And if you don't have a phoropter, takes a little longer maybe to do some of these things. So then the accommodative facility would be great to do.
Oh, thank you, ma'am. I have one more. Hello?
Yep.
I have one more. In that case of Jack, what you did in first attempt, you give 2 prism diopter base down and 0.75 diopter plus. So is there any criteria how much prism should be prescribed base down, or in every esophoric cases we
That's a
should
very
provide
good
base down?
question. The plus I certainly determined from the NRA, PRA, and the fused cross cylinder. I could also do near point retinoscopy to get that. The amount of yoked prism that I might use is something that I test in 2 ways. One, I generally, although there's a lot of amounts, some people want to give a half, some 1, I never go more than 2 in each eye. A lot of people like to stay lower than 2. I've had a lot of success with 2, so I find myself reaching for that a lot more. I don't know why I have had good success with it, but I usually try 1 or 2. And one of the things that I do, and let me grab it here and I'll show you. Is I sometimes use a card that has, can everyone see this? This is called a McDonald's farm field card. There are, believe it or not, there was an artist who developed something like this a number of years ago. But what I do is I ask them to look at the center of the card, and then I ask them to try not to move their eyes and let me know how many of the letters they feel like they can identify. And then I put the yoke prism on, and if they say either it's clearer or they notice much more, then I know it's a good lens to prescribe. But I tend to think about it, especially for a child who's showing esophoria at near, because I know it's likely while they're working, they're really constricting their visual field. But
thank you, ma'am. Thank you.
One or two prism diopters in each eye.
Thanks, ma'am. Thanks.
Somebody somebody asked about the 2 base down, so I just talked about that. And then thank you for asking that, because I didn't put a lot of that in the presentation. And someone said, can you give a sample of a few questions asked in the questionnaire to objectively assess a patient's binocular status and symptoms related to binocular vision anomalies? Well, we asked, do they ever see double? We ask if words move on the page. We ask if they notice, for example, at the end of the day that their distance eyesight isn't as clear. We ask if they lose their place when they read. While that can be oculomotor, it can also be that their ability to maintain binocularity is unstable. So one question is not always going to cover just one thing. So if they're losing their place, it could be oculomotor, it can be accommodative to some extent, but more so binocular. I also think that we have to remember that all these things work together. So if one thing is off, it's likely that even if the other skills are relatively good, the balance between them isn't going to fit well. So I don't spend a lot of time anymore saying it's an exact diagnosis. The only thing I'll use a diagnosis for is when I have to fill out a form so the parent can get reimbursed for the exam. And primarily here, it's mostly convergence insufficiency. So if they're convergence excess, I got to make up something that fits. But primarily, I ask if they get tired when they do things. Do they play sports? And if they do they feel like they have trouble, hitting a ball, catching a ball, whatever it is at particular ages that they do. I like to ask a lot about their daily lives because I want to have a sense of what do they want to be doing that's challenging for them. I never use the word hard here. I always say challenging. And I also want to know, are they avoiding any activities that you would expect someone to be doing, especially a child? Somebody wants to know what the visual skills are, what the telebinocular tests are. Hang on, and I'll grab those cards. I don't know, the cards apparently are not in my telebinocular at the moment. I'm not sure where they landed. But I will say this, if you are looking, this is the form I use to fill out. What it does is it starts off showing, for example, a dog and a pig. And if it's the way it should be, let me just hold it here so I can show you, because I'm not sure where my card is at the moment. It will show you the dog and the pig. If they tell you that it looks like the dog is right over the pig, then that is in the normal range. And so what I do usually is I take a pointer and I point to the stripe on the middle of the dog's back, and then I move the pointer a little left or right and say, well, tell me, or actually I put the pointer on the page and say, tell me when I'm right over the stripe on the dog's back. And then I see where that is in relationship to the pig to make sure that they're describing it correctly. And then there's a group of numbers where it will look like an arrow is pointing to a number, and you can find out if it's pointing in the expected range or not. Or it can be in the expected range, but they'll tell me the arrow is moving. Well, that tells me something. And this is distance. And then at near, there are 4 dots that they need to fuse. Then there's a section for acuity and first degree stereo and even some color vision. And then they have the same 2 tests for near. You actually move the cards closer in, and there's one with the arrow and the numbers and one with the 4 dots. There are some even automated tests that are similar. I think if you're familiar with the HTS vision therapy program, they have one or had one that was a way of assessing some of these skills on the computer. You would use red and blue glasses, and even with the joystick, they could move or either tell you where it was, or in some cases it was even hooked to a joystick, and they would move like a cross until it was lined up with a box, things like that. But you could create something like that easily yourself and do it in any kind of stereoscope. We just have to look at the distance and make sure that, you know, the measures work. I have other stereoscopes here that have cards like that, you know, similar to that. Also, somebody made one and it was very cute. I think it's a crayon and it points to, like, you know, a picture and, you know, with some kids' toys that line up. I have some that are for very, very young children, and you can ask them, for example, when they're looking at fusion, they have a picture of a clown. And if they're fused, it'll look like he has a little bow tie under his chin, and it looks like he has a little hat on his head. So there are ways to do it for anybody. And to be honest, if all I had was some of the you know, kids' pictures, adults like that too. Many years ago, I had my little gold ball and my little silver ball that I used for saccades, and I had an adult, and I just happened to grab the silver one to do a pursuit with her. And she said to me, and this woman was probably 75 years old, she said, "What do I have to do to get the gold ball?" So adults like some of these fun things as well. Someone else asked, how do you coordinate between office vision therapy and home vision therapy? If I have someone that has very mild symptoms and I think that they could do some things at home, I will sometimes recommend that. Although I know that follow-up at home isn't always what we'd like it to be. But if I think that they'll do it at least for a few weeks and then come back, maybe I'll give them 1 or 2 things to do each day at home, just for a short period. And then most of the time we're doing office vision therapy with having them do supportive techniques at home. Not everyone is good about doing their home therapy, and those that aren't don't progress as well or as quickly. You know, every time I have someone who does very, very well, I will often try to look at their chart and say, wow, you know, did I do a different combination of techniques? Did I learn something new? And most of the time I find that I send a sheet home where they can keep track of the homework they do. And their homework sheet is just covered with notes, meaning they're very serious about it. What age can we rely on the subjective responses of the tests? Well, I do find that if I'm doing something like my telebinocular tests, I can even get some 3-year-olds to give me responses there. But in the phoropter, it's a little bit harder. Probably, again, 4 or 5, depending on the child. I mean, I have some 9-year-olds I can't rely on. You have to kind of get a sense of that. I try to show them what I mean. For example, if I want them to line up 2 targets for aphoria, I take my fingers and I say, I'm going to have one here and one here. And I want you to tell me when it looks like this one can fall right down on the other one. Probably I should make some pictures, you know, like a rocket falling down on something or shooting up to something, or, you know, something that they're interested in. But I do find that most kids can tell me. And again, if the numbers are all over the place, once in a while, it's because that really is what's going on. But in other cases, maybe I can't rely on that. Maybe then I pull out a muscle balance card that uses a Maddox rod and a pen light so they can point where they see the line crossing the page. Maybe I use a prism bar in free space so I can watch their eyes more. So there are ways to do that. I mean, not every child is reliable. Not every adult is so reliable. And with so many tests out there that can be done, which ones are a must do that even resource limited centers can do? Again, everyone can do a cover test. I need nothing to do a cover test and a near point of convergence and a pursuit and a saccade. And I can do all of those things with something very simple that's sitting around. I can use my finger if I have to, but an accommodative target is nice. Sometimes when I'm out and about and I need to do something like that, I just grab a stick, like a plain little art stick, and I draw a little smiley face on it, and that's what I use. It's not very hard. I don't think you need a lot of the formal tests that are out there. They tend to be fairly expensive, but I do think that I like some of them as a baseline and something to go back to. But I can go back to other things. I have a lot of simple, even paper and pencil tests that I do with children when I'm looking more at higher level perceptual skills, and they don't cost me anything. I type them out and I make copies of them and I just use them. Or I might have to get something once that I can use over and over and over and have used for many, many years. You know, like my Keystone telebinocular was not the most inexpensive thing, but I bought it many years ago and it has paid for itself. I can't tell you how many times over in using it. I know that we're going to do more of a fellowship program and try to do more in terms of working through all the levels of even basic vision therapy. And so that's where we can get into it more. And someone else mentioned that they also use some kind of questionnaire, like the 30 question COVD questionnaire, and that they do find it easy to see a person's progress by how many points they get, because I don't show them their first one. I just hand it to them again, and it's usually been a couple of months, and so they don't always remember it. And I have them fill it out again, and then I show them how they did on the first one. I never tell them that they did it once before. Sometimes they'll say, didn't I see this before? But that's very rare. Most of the time, they don't even remember, because we've done so many things. Any more questions? I think we're doing great. And I really appreciate your staying here for a little extra to go through the questions. And, you know, if anything else comes up, I am around. But I do think that if you want to feel like you can get into it more, especially adding it to a general practice, you do not have to have a specific vision therapy practice. You do not have to even do active in-office vision therapy if you don't want to. I'm telling you, over the years, I don't dispense eyewear in my office now, but when I did, I probably dispensed a lot more eyeglasses and made a better income because of it. Again, because it was a win for the patient as well, because I prescribe a lot for kids and even adults that are not necessarily thinking that that's what's going to happen. So it's good for them and it's good for you. I'm looking if there's anything else. Nope, I think we covered a lot today. If you feel a little overwhelmed, that's okay. go back and do one or two things you don't already do consistently. First of all, when I learn anything new, whether the patient absolutely needs it or not, if it's not going to hurt them, they all get it till I get better at the test. Okay, so if you don't do a cover test on a regular basis, go back and do it. Just look. Don't worry if you have an exact diagnosis, if you know exactly what you're seeing, just do it. Do an NPC on everyone under, 35. Try doing a simple pursuit or saccade. Just do these things a little bit more until you get more comfortable with them, because then you'll see that they don't take very much time. In the beginning, they're going to take you a little longer because you're not as comfortable with them. And that's true for me too. But once you get into it, you can do all those things in like a couple minutes, very quick with most patients. And it's fun. And I like it, and patients like it, and they're very appreciative. And more importantly, anything you give to, especially to a child now, they get to take that with them their entire lives and will probably be more successful and more productive in life because of having better visual skills. So anything else, or is everybody ready to go to sleep there, I guess? I'm just starting my day. I'm about to see patients. Are we good?
Okay. So Solu, can you please unmute yourself?
Yep. I'm not muted, I don't think. Oh,
Okay.
anybody else or me?
Yeah, there is a.
Yeah, I guess we have answered almost all the questions till now. And it was indeed a wonderful session by Dr. Cathy. Thank you so much for your presence, Doctor.
Thank you. This was fun.
Herewith, I announce the closure of today's discussion session, and I would again like to express my immense gratitude towards our presenter, Dr. Cathy, and to all the attendees for their endurance. Also, I would like to thank all the direct and indirect helping hands for the iTux program. Before wrap up, I request our today's presenter, Dr. Cathy, to share her few words to our program.
And thank you for your time, and Kapil for getting me involved with this. And I know we'll do more.
Sure, Doctor, we would love to see you again in the future. Herewith, I announce the closure of today's webinar, hoping to see you all again tomorrow. Stay safe, stay connected. Thank you.
Bye-bye.
Bye, Doctor.